Greetings, class. My name is Shantia Levin, and today you'll be viewing a web of causation on breast cancer in younger adult women. My goal was to look at women with breast cancer who were 40 years of age and younger, but you'll see in my literature review that the age ranges in a lot of these articles vary. However, I hope that you learn a lot of new facts and enjoy my presentation. Thank you for watching.
Sobering new information this morning about women and breast cancer. A study just released by the Journal of the American Medical Association reveals an increase in advanced cases among women under the age of 40. Dr. Nancy Snyderman is NBC's chief medical editor. Nancy, good to have you here. This study is going to worry a lot of women across the country, especially younger women. What's the headline?
The headline is that these are small numbers, but statistically significant. It's showing the more aggressive metastatic kind of cancers, the ones that spread throughout the body, in women 25 to 39. And the concern is these are the cancers that are more aggressive. They're not the ones that women go looking for because we don't do mammograms in younger women. And these are the women who a lot of times don't have insurance.
Let's break it down here. The numbers, as you mentioned, relatively small, about 3 cases per 100,000 in that younger age group. But since 1976, that number has basically doubled.
And the question then is why? And the researchers don't know that. So we're starting to look at, okay, what are the environmental factors? Could this be the canary in the gold mine that we are now fatter? And because fat holds on to toxins and some hormones, could that be a harbinger of things to come? Could it be that children are starting their menstrual cycles earlier, 8 and 9 years old, so they have more hormones pumping through their system? We just don't know.
And touching on a point you just made a second ago, the fact that these cancers tend to be more advanced and then deadlier than cancers in other age groups, is that because these young women simply aren't screening?
No, it means that a lot of times when you are younger, something has gone wrong with your immune system already, so these cancers tend to be more aggressive. But I want people to hear one thing. This does not mean we start screening with mammography for 20 and 30-year-olds. We still hold to our regular standards, but we start to figure out, okay, what causes breast cancer? And that's our weak link.
All right. Again, a lot of people are going to be looking at these headlines this morning, Nancy, as always. Thank you.
There are some important facts to know about breast cancer, which I won't go over in their entirety, but you can refer back to the PowerPoint for more information. Breast cancer is a cancer that develops in the tissues of the breast. There are 2 main types of breast cancer, which include ductal carcinoma and lobular carcinoma. Breast cancer can be invasive or non-invasive, and estrogen can cause cancer growth. Symptoms of breast cancer include lumps, changes in breast or nipple size, fluid from the nipples such as blood or yellowish-green pus, and symptoms of severe breast cancer include bone pain, breast pain, skin ulcers, swelling of the armpit, and weight loss. And many of these symptoms can be self-detected. Diagnosis for breast cancer includes a breast MRI, a breast ultrasound, breast biopsy, a CT scan, a mammogram, a PET scan, and a sentinel lymph node biopsy. And this information was retrieved from Medline Plus 2013. Every 1 in 8 women are diagnosed with breast cancer during the course of their lives. Women under 40 have a 5% chance of getting breast cancer. And shockingly, women under the age of 50 are more likely to have invasive breast cancers. Men may also be diagnosed with breast cancer. However, breast cancer is 100 times more likely to appear in women than in men. In fact, it only affects 1 out of every 1,000 men. Now let's transition to the literature review to examine the determinants of breast cancer in younger women. For the full summary of the articles mentioned in this presentation, please refer back to the PowerPoint. In Epidemiology of Breast Cancer in Young Women, Poland 2010 examines the epidemiology, incidence, and risk factors associated with breast cancer in young women. The determinant that she suggests is related to breast cancer in young women is genetic predisposition. Young women with BRCA1 and BRCA2, which are tumor suppressors, have a high risk of developing breast cancer in the early stages of life. These genetic mutations are harmful and directly related to the diagnosis of breast cancer in younger women. In addition, most women with these mutations have family members who have been diagnosed with breast cancer. The claims of Poland are substantiated by Malone et al. 2011, who studied the relationship between inherited predisposition, breast cancer phenotypes, and mortality and family history of breast cancer in relation to tumor characteristics and mortality in a population-based study of young women with invasive breast cancer. These researchers compare findings for women with a first-degree family history of breast cancer, which includes children, siblings, and parents, with women who have a second-degree family history of breast cancer, which includes grandparents, aunts and uncles, nieces and nephews, and grandchildren. They conclude that family history is directly correlated with the early development of breast cancer in young women. In addition, they conclude that the risk of death among women with a first-degree family history of breast cancer decreases by 40%, and that those with a second-degree family history of breast cancer are at no greater risk for death. I included this study to validate the claims of Poland that genetics is a major determinant of breast cancer in younger women. Yankaskas 2005 validates the claims of the previous researchers in epidemiology of breast cancer in young women, in that she examines the low incidence of breast cancer in young women in comparison to older women, the severity of cancer in younger women versus older women, the high rates of reoccurrence in young women, and the low survival rates among young women with breast cancer. And she looks at the common risk factors for breast cancer, which include race, family history, radiation, and late age at first birth, and those risk factors more specific to young women, which include contraceptive use, radiation, and smoking. She finds that oral contraceptive use may or may not contribute to one's risk of breast cancer. The risk associated with contraceptive use decreases with age, is related to dosage, and affects women under 35, and is restricted to ER tumors, which are hormone receptor positive cancers that grow at slower rates. Smoking is linked to ER plus tumors as well, but there is more research to be done to verify the link between smoking and breast cancer. As far as race is concerned, though white women have higher rates of breast cancer overall, younger black women have higher incidence rates of breast cancer than younger white women. Other factors that are more discernible in younger women include late pregnancy, radiation exposure, especially for Hodgkin's disease, which will be explained later in this review. This information was retrieved from Yankaskas 2005. From Yankaskas' study, we can assume that age contributes to the aggressiveness of breast cancer. Comparatively, in breast cancer age-related factors, Odo 2012 examines the ways in which age may have contrasting effects on younger women and older women. And she finds that the developmental stages of the breast, the early onset of menarche, age at pregnancy, and breast density are risk factors for young women. Disruptions in breast development may contribute to the development of cancerous tissues. The early onset of menarche is a risk for breast cancer because cells replicate at a fast rate, which increases exposure to carcinogens. Developing breasts are ultimately more vulnerable to these carcinogens, which is a cancerous subject that helps cause cancer. For women who become pregnant in their 30s, their risk of breast cancer increases because the duration in which they are more vulnerable to carcinogens extends. Lastly, dense breasts are associated with younger women who have a 4 to 6-fold increased risk of getting breast cancer. And this information was retrieved from Odo 2012. In Breast Cancer in Young Women and History of Selected Medical Conditions, West et al. 1999 explored the relationship between medical conditions and breast risk. And these medical conditions are listed on the PowerPoint. And at the end of the study, they don't find women who had a history of any of these illnesses to be at greater risk of getting breast cancer. However, in one case, there is a correlation between ovarian cysts and breast cancer. For women who had not had an oophorectomy, which is the removal of the ovaries, were at greater risk of getting breast cancer. The medical conditions outlined in the previous article are a result of one's living conditions. In Bastro and Affelstedt's 2010 article, Breast Cancer in Young Women in a Limited Resource Environment, they assess the ways in which young women 35 years and younger in developing countries who have been diagnosed with breast cancer have fewer resources than those in Western society. They find that living in a limited resource environment is indirectly related to breast cancer. For if one's living environment limits the medical care and treatment one receives, there may be increased rates of reoccurrence, increased rates of mortality, and late cancerous discoveries. Oregon et al. 2011 extend the claims of Bastro and Affelstedt in breast cancer incidence and neighborhood income, where they examine the relationship between income and diagnosis of breast cancer in women 19 and older. These researchers find higher incidences of breast cancer in neighborhoods with high incomes than those in lower income neighborhoods. This association may be based on parity, the number of times a woman has given birth, and age at first birth. Parity helps to decrease the estrogen exposure when menstrual cycles aren't present, and since women in higher income neighborhoods have fewer children than those in lower income neighborhoods, they are less likely to be at risk for breast cancer. Gathered from Borgen et al. 2011. In recommendations for the surveillance of young women at increased risk for breast cancer, Haddon 2007 examined surveillance techniques and whether they may put young women at higher risk of getting breast cancer. This study ends up being inconclusive, but at the end of the study, she does find that radiation in early life may injure normal breast tissues and put young women at greater risk of getting breast cancer. Also, abnormal cells in the breast raise risk because if they don't die off, they have the potential to duplicate and cause breast cancer tumors. Lastly, Haddon does not discuss the correlational relationship between lobular carcinoma in situ and breast cancer, but it is directly related to the risk of invasive cancer in the same or both breasts. The information was retrieved from Haddon 2007, and to get clarity on some of the ideas that Haddon doesn't discuss, I looked to Medline 2013. Now please view my web of causation to understand the ways in which the determinants are related to breast cancer and in some instances to each other. Please view. Now let's examine a social work perspective that addresses the issue of breast cancer in young adult women. A group of health and social work providers came together to evaluate and come up with a model to assess the experiences, needs, and concerns of younger women with breast cancer under the age of 45. They developed their conceptual model based off of a meta-ethnography. According to Adams et al. 2011, meta-ethnography is a synthesis of evolving research and seeks to maintain the character of qualitative research studies through a collection of themes from the text and to provide new interpretations of these texts. There are 7 phases to the scholars' meta-ethnography. These phases inform the development of their conceptual model. From the conceptual model, these healthcare and social work providers find that young women with breast cancer face varied experiences, which demonstrates their need for support, information, child care, counseling, and spiritual support, which will help them to cope with having breast cancer. The concepts that arise from the meta-ethnography can be viewed on the next slide. Now let's examine a community-based response stationed in Boston, Massachusetts. The program for young women with breast cancer at the Dana-Farber Brigham Women's Cancer Center provides assistance to women 42 years of age and younger at diagnosis. The goals and components are the same, which are to promote education, clinical care, and research. The effectiveness has been tested since 2005. Since then, it has served more than 1,600 women at the age of 42 or younger over the last 6 years. More than 100 young women have participated in facilitated groups. The Young Women's Forum that began 8 years ago now includes lectures from medical professionals, a survival panel, and an Ask the Expert session. There is now a multi-institutional prospective cohort study of women with breast cancer 40 and younger. They recently began a new lecture series in 2011, and they are currently pilot testing Young and Strong, which is an exportable model of the current program that will serve young women with breast cancer who are not obtaining care outside of the cancer center. Now let's look at a health policy that addresses breast cancer. The Breast and Cervical Cancer Prevention and Treatment Act was passed in 2000 by President Bill Clinton. It gives states the option to provide medical assistance through Medicaid to eligible women who were screened for and found to have breast cancer or cervical cancer, including precancerous conditions, through the National Breast and Cervical Early Detection Program, or the NBCC-EDP, according to the Centers for Disease Control and Prevention 2013. All 50 states, including the District of Columbia, have chosen to provide Medicaid coverage for women diagnosed with breast cancer through the NBCC-EDP so that they will be able to afford treatment, according to the American Cancer Society 2013. This act has now been subsumed under the Affordable Care Act. The NBCC EDP targets women in low-income areas, uninsured women, and underserved women. The goals of the program is that it seeks to reach as many underserved women as possible, detect breast and cervical cancer in its early stages, and provide diagnostic screening to women who may be at risk for breast cancer. The program has been tested for its effectiveness. Since its emergence in 1991, there have been over 10 million screenings provided to underserved women, over 51,000 breast cancers, more than 142 precancerous cervical lesions, and over 2,900 cervical cancers have been diagnosed. The weakness of this program is that it neglects the issue of breast cancer in women under 40 and sparingly offers services to those between 40 and 64. Thus, even with this program, there is still a big population of underserved women. Women in their 20s and 30s are discouraged from breast cancer screening, so there needs to be a component to this program that studies the causes and history of breast cancer in younger adult women that will possibly increase survival rates. Please view the slide labeled Conclusion for a summation of this PowerPoint, and thank you for listening to my presentation.